So I was born in Beijing, China. Came to this country 30 years ago. I came over as a graduate student. After I finished the medical school in China, I was thinking about, become a scientist actually for a while. And then, so I came over, went to graduate school in Georgia. It's called Medical College of Georgia. And it's kind of old-fashioned graduate school. They actually require you to take some of the medical school classes with the medical students. So I actually retook a lot of the standard medical school classes like physiology, pharmacology stuff. And then I was in the pharmacology department as a graduate student, and I went through 5 years there, and then got my PhD. However, I was observing my professors, struggling to get fundings. They have constantly writing grants, basically, and then do things that they don't want to do, but they have to depend on that to get money so they can do things that they like to do. So it's kind of a constant struggle as well. So I kind of lost interest in being a professional scientist. And so I took the, board exams and everything. And then I was interested in the anesthesiology department, of course, kind of because it's more closer to the research stuff, background, etc., and pharmacology, physiology, like that. So I went to the anesthesia residency in Pittsburgh, and then moved over to Oregon State and started working. My father was a doctor in China. I kind of grew up in the, inside the hospital for the longest time, I would say, because back then, there weren't that many. They were before the pagers in China, so they actually have to either call the phones in your neighborhood to find you if they need a doctor to go to the hospital for some emergency, or they have to send someone to find you. It's basically, you don't live very far, It's almost like that's the whole idea of the residency started. Basically, if you're a resident, you live in the hospital. That's where you're supposed to be available immediately, anytime. So anyway, so I kind of got a sense of what hospitals like and what medicine's like from just reading around his books and everything, and possibly from talking to friends. Patients were thankful to him back then. I remembered, of course, back then they didn't really earn that much money either. But however, they do get some little gifts from patients, family members, or from patients, or they do a favor by basically helping friends, helping relatives, people actually coming from afar, looking for help. I thought, he's very much in demand. Is always welcome to most people. And nowadays, I think it's very different now. But it's more commercialized, of course. But back then, I think just I thought it's a secure career. Basically, it always is. Well, the anesthesiology is started, about 150 years ago, basically trying to do operation to make people not feeling it. Basically, you try to keep people unconscious. They don't move, and they're not aware they've been cut on. Also, we try to make people pain-free. So it's called analgesia. We have to treat all the symptoms come with operating on a patient. Basically, when you cut on a patient, even when the patient is asleep, anesthetized, there's still heart rate going up. The patient's still gonna have, breathing, speed up breathing, etc. So we need to control the sympathetic response, basically. So the anesthesia is actually not just unconscious and pain, and we have to basically keep the patient alive and as close to normal physiological state as possible. So basically, we do the ABCs for the patient inside the hospital. We're almost like the paramedics of the hospital. Basically, you keep the patient the airway, pay attention during the surgery, breathing, and also circulation. That's the ABC. Well, basically, we try to find out. We usually know ahead, the night before, what kind of cases you have next day. Maybe, for example, say you have next day you have breast cancer surgery, like 3 patients in a row. So basically, we try to look through their computer chart these days. Back in the old days, you had to look at paper chart. Now at least you can look at the computer chart, see if they're sick or not. Some people are chronic medical problem, like I said before, bad breathing problems. They're gonna have hard time breathing after surgery. Some people have bad heart. They have heart failure. They may not take a strong dose of the pain medication, or even just a strong dose of the propofol. So we have try to go through that history if you can, and the next morning, early morning, we usually start the first case at 7:30. So you basically try to meet the patient at 7 o'clock. Make sure there's no last minute problems. Say patient forgot to hold their breakfast. Say, okay, I just had a big glass of milk and a big cookie this morning for breakfast. So now we can't really have surgery because we don't want you to aspirate and stuff like that. Again, next patient, we do the same thing. I'm not a big talker. I'm gonna have to talk to you about, your diet and everything, your living conditions, everything. Okay, how do I describe the coronary artery disease and everything, and then coming back in a month, and we'll do the same thing again. I would rather just do something have immediate effect. It's unpredictability. If someone's new, it could be kind of hard to predict. Okay, what is you just don't know, something bad may happen. It can happen. So I learned a lot of techniques and or refine my own techniques, just or refresh my own techniques, and from watching YouTube, stuff like that. And I think it helps. Once in a while, I need to watch it just so I can remember. Okay, this is the way it's supposed to look like. And there's unfortunately not a whole lot of a major development within the anesthesiology per se, I would say. The thing is, we're kind of we're kind of serving the surgeons and the surgical procedures. I mean, for the last 20 years or so, we're more focused on patient satisfactory, patient's level of satisfaction after surgery. The one thing always standing out, is the pain control. Especially after arm surgery or leg surgery. So we do some regional nerve block. Basically, you put local anesthetic into the arms and legs, try to basically numb up the nerves. Like the dentist numb up your teeth, you can numb up the nerves on your arms and legs, try to do pain control. So there are ways. In the old days, you just go by anatomy and do it. Later on, people use nerve stimulator, called a nerve stimulator, trying to find the nerve closer to the nerve as possible. You can observe the limbs jumping from the stimulation, and then you inject the numbing medicine around it. Nowadays, you can use ultrasound, we call it sonocyte ultrasound device. Basically, you can look for the nerves, look for the vessels, blood vessels, look at the veins and arteries, and avoid them or stuff like that. And you can look for the nerves, and then you can do the nerve block under ultrasound. I would say, if you're really, really interested in medical school, just think about medicine is about people. That's the thing. People is the most variable part of the whole system, I would say. I don't know how to put this, but you think, when you get into medical school, you help people, But a lot of times when you're in a big hospital, major city, you deal with people that they may or may not want your help, and it's hard to help people just by thinking about helping people. Uh, some people will come in with gunshot wounds once every 6 months. You may almost think like maybe you should have a zipper on their belly, so next time you don't have to go through all this. It's easier to open it up. Like I said before, if you're thinking about raising the whole population's health, medicine doesn't really work that well. You need societal effort. Basically, majority of the medical issue, I say, is social issue. You have to think about that way until the whole country decided, okay, we need to work the whole country in a socially responsible way. By individually treating the patient, just not going to be efficient as it is. But also, I would say the majority of the social problem is really the family problem or the lack of family. That's what I said. So if you pick up the problem within the family, and if you treat that problem first, eventually I think you can treat the whole society. But anyway, if someone really wants to do the scientific part, if you're really interested in the medicine from a scientific point of view, that's great. It's easier that way if you just deal with the scientific part of the way.